Yeah, open, sir, open.
Yes, make public.
Yeah, so this is our third webinar from Back to Basics, and we welcome all the participants, the speakers, moderators, and the panelists. So I welcome everyone, and I request Dr. Roopesh to start the proceeding.
Thank you, sir. Thank you. Good evening, everybody. So last month, we couldn't have the meeting because we had the interim meeting at Bhopal. So we had to push to this meeting. This is a very important meeting. Anterior clinoidectomy is again a very basic procedure, which is like a workhorse for many skull-based procedures. So going with the topic, the theme of the webinars, back to basics. I think this is very important for every young neurosurgeon to know when it is indicated and what are the techniques, what are the different types, and how to do it. So we have a very good team of speakers for this meeting, and I invite Dr. Ved Prakash, Additional Professor of Neurosurgery from SGPGI, Lucknow, to be the moderator, and then he will start. Dr. Ved, can you please start the proceedings?
Yeah. Thank you, sir. Thank you for the kind invitation. And at the outset, I am grateful to the Executive Committee and Scientific Committee of Skull-Based Surgery Society of India for taking up this initiative of starting the webinar series, which is increasingly becoming popular in our fraternity. On behalf of the Skull-Based Surgery Society of India, I extend my warm welcome to our esteemed panelists and speakers for today. And let me introduce the panelists today. Our panelists are Dr. Tripathy. I think he is traveling somewhere, but he will join soon. He is Director of the Medical Institute of Neurological Disease and Vice Chairman of Medical Super Specialty Hospital in Calcutta. And Dr. Raghavendran R., who is Director and Head of Department of Madras Medical College, Chennai. Area of interest are complex skull-based surgery and cerebrovascular surgery. So, can I share my slide?
Yes, sir.
As we know that anterior clinoidectomy is a very basic and essential technique. And the theme of this webinar is back to basics. And the topic for today is anterior clinoidectomy. So anterior clinoidectomy, can I share the slides?
Yes, sir.
Yes, sir.
Am I visible?
Yes, sir. Audible.
So this technique was developed and popularized by a visionary skull-based neurosurgeon. He needs no introduction, Professor Vinko V. Dolling. He introduced this technique in mid of the 80th eighth decade in the 20th century. The slide is not moving.
Sir, press once on the slide, it will be.
Yeah. So with this, I would like to just start with a case capsule. A 55-year-old lady who presented with sudden onset of severe headache and drooping of right eyelid for 10 days. Plain CT scan shows streak of bleed in the right ambient cistern. Maybe that may be a sentinel bleed. So once we get the CT angiogram done, we found that there are two outpouching in the internal carotid artery and posterior complement artery junction, that is ICA PCOM, more on the right side than on the left side. So most probably the right ICA PCOM might have bled. So what to do? Whether to go ahead with clipping of the aneurysm with clinoidectomy or without clinoidectomy. And the second case is a 40-year-old lady who presented with visual diminution in left eye for last 6 months. Her MRI, T2 MRI suggests that there is an ISO to hyperintense lesion based on the left clinoid, which is encasing the clinoidal and supraclinoidal part of the ICA and displacing anterior cerebral artery and middle cerebral artery. So the choice is whether to do clinoidectomy or not. Yes, definitely we have to do the clinoidectomy, but whether to do intradural or extradural.
So I think the picture is hiding the images. We are
Yes.
not able to see the second row of image where the lesion is. It is
Yeah. So this much only was the target image, sir. I was focusing on the lesion only. So now to discuss on this, whether to do clinoidectomy or not, how to do the clinoidectomy, and what are the associated complications of this. As very well pointed out by Professor Roopesh, sir, that is a very basic and essential step of all the skull-based lesions, which every neurosurgeon must master this. So to discuss about the indications and neurosurgical anatomy, we have a very eminent speaker list today. So I would like to introduce our first speaker, Dr. Edmond Jonathan. Without further ado, I would like to introduce my first speaker, who is Professor of Neurosurgery at CMC Vellore. Over to you, Dr. Edmond Jonathan. So,
Thanks, Dr. Ved.
yeah, speakers are allowed to give their talk for a period of 12 minutes, and we will have discussion at the end of all the talks.
Dr. Tripathy has also joined. It seems.
Thank you.
Sir, good evening.
Welcome, Dr. Tripathy.
Thank you. I'm sorry. I'm in a conference in Dresden, Germany. The session is going on and just come out. Sorry to be late in joining. Please carry on. Thank you, Doctor.
Thank you,
I
sir.
came to listen to Dr. Jonathan and other speakers. Thank you, Roopesh. Please carry on.
Thank you, sir. So is my screen visible?
Yes, sir.
Yes, sir, it is visible.
Thank you.
Very pretty picture. Very pretty picture. Please carry on.
Thank you, sir. At the outset, I would like to thank Skullbase Society of India and the executive members and the panelists and the moderators for giving me this opportunity to share my thoughts on surgical anatomy of the anterior clinoid process. Why clinoid? The anterior clinoid process, it's a unique bony process. We know that there are many anatomical variations and limitations. It has direct relationship with very different critical structures of the brain, and it also has various dural attachments and ligaments. It has a diverse growth pattern. Understanding the anatomy and understanding the variations of the anterior clinoid process sets the pace for understanding the better anatomy and operating in these areas with so many vital structures. As we all know, anterior clinoid process is a pyramidal shaped structure. It's an extension of the lesser wing of the sphenoid. Lateral wall, it forms the lateral wall of the optic canal, and between the two anterior clinoid process lies the sella turcica. The anterior clinoid process also forms the anterior roof of the cavernous sinus, and the posterior and the inferior portions of the anterior clinoid process forms the border with the internal carotid artery. It's derived from the word clean in Greek, which means bed, and in Latin clinaire means slope, which justifies the name clinoid. This picture is of paramount importance for our discussion. Understanding the terminology and the anatomy forms a crux for understanding the talk. As seen here, the J stands for the jugum sphenoidal, following which we have the limbus and the prechiasmatic sulcus, tuberculum sella, and we see here anterior clinoid is denoted with an yellow paint. And yellow picture also denotes the posterior clinoid, and we see an in the prominent structure, the middle clinoid process. Understanding this picture is very important for the future of our discussion. What are the roots of the anterior clinoid process? Anterior clinoid process has a superior root, which is formed by the roof of the optic canal. It has an inferior root, which is formed by the ventral and lateral wall of the optic canal. An inferior medial, this is formed by the optic strut. The study by Dactin et al. On the anterior clinoid process anatomy, they have come to a conclusion, and they found that in their study that average width of the anterior clinoid process is around 7.3 mm from here to here. An average length from here to here is around 10 mm, and the height corresponds to around 5.4 mm. Interestingly, many of the cadaveric studies have shown that Indians have the longest anterior clinoid process. As seen here, the superior orbital fissure forms the inferior and lateral wall for the anterior clinoid process. A study by Wu et al. On studying the 6 surfaces of the anterior clinoid process in their classification found that this is very important in order to understand the paraclinoid anatomy well. So the first surface is the frontal surface as seen here. described very clearly, which has relation to the frontal lobe. The next is the optic nerve surface, which has this attachment towards the optic nerve, and the surface towards the optic nerve is defined as an optic nerve surface. Then we have a temporal surface, which is the lateral and inferior boundary. And we have the third nerve surface as seen here, which lies in close relation near the superior orbital fissure. There is also an optic strut surface that is seen here, which is very close to the optic strut, and ICS surface. Understanding this 6 surface concept of anterior clinoid process helps in understanding the paraclinoid anatomy well, and also helps in easy removal of the anterior clinoid process. What are the anatomical relations that we are important for the anterior clinoid process? We have the orbital roof, which is superior and anterior. We have the superior and medial optic canal and planum sphenoidal as a continuation of the jugum. Superior and laterally, we have the lesser wing of the sphenoid. And inferior medial, we have the optic strut. We have studied this. Why is superior orbital fissure very important? We all know that the superior orbital fissure is bound superiorly by the lesser wing of the sphenoid, inferior laterally by the greater wing of the sphenoid, medially by the optic strut. The superior orbital fissure admits the third nerve, oculomotor, trochlea, abducens, and V1 and sympathetics of the carotid. So any inadvertent breach into the superior orbital fissure can cause damage to the structures passing through the superior orbital fissure. Let's look at the dural relationships that are associated with the anterior clinoid process. The anterior clinoid process sends out 2 dural reflections, in fact 3. The first one is the anterior petroclinoid. This is a dural fold that extends from the tip of the anterior clinoid, goes to the petrous apex. The next is the posterior petroclinoid fold that extends from the posterior petroclinoid process to the petrous apex. There is also an interclinoid fold that extends from the anterior clinoid process to the posterior clinoid process. It's not well defined. Between the folds of these petroclinoid ligaments lies the third nerve. And the third nerve has close relation near the anterior clinoid process. It divides the superior division and inferior division. Any damage as it's entering into the superior orbital fissure, any damage to the anterior clinoid process drilling can damage the superior division of the oculomotor nerve. What happens to these dural folds? Medially, we see that they join to the sellar diaphragm as seen here to form the diaphragm as well. Anteriorly, the dura goes over the orbital portion of the frontal lobe. Posteriorly, the dura blends into the dura over the basilar plexus. Laterally and inferiorly, it joins the inferior wall, lateral wall of the cavernous sinus. So this is how the dural reflections of the anterior clinoid process are important and how it ends. A brief note about falciform ligament. Falciform ligament is a dural fold that extends from the medial border of the anterior clinoid process and drapes over the optic nerve and then joins to the jugum sphenoidale. This fold covers almost 3 mm of the optic nerve under its length. Sectioning of the falciform ligament is of paramount importance whenever we need to maneuver and look under the optic nerve. For example, in case of paraclinoidal aneurysms, ophthalmic segment aneurysms, and in removing the tumors that have gone underneath the optic nerve, especially in the clinoidal meningiomas. This helps in order to prevent the undue stress on the optic nerve causing visual disturbances. Fukushima, in his manual of skull-base dissection, described anterior clinoid process resembling a shark's tooth. As you can see, it resembles a shark's tooth. He also made a point that anterior clinoid process, if small, can be removed easily. However, if there is a large process, and it can be difficult, and if you do not study the anatomy well, there is a chance that it can injure the neurovascular structures. Shark's tooth for the anterior clinoid process. What are the other dural reflections that can be studied in relation with the anterior clinoid process? Is the distal dural ring. As seen here, the distal dural ring is the extension of the dura medially over the anterior clinoid process. The distal dural ring, also called as Perniskis ring, it is a complete ring, and it fuses with the adventitia of the internal carotid artery, and it is adherent over the dorsolateral aspect of the internal carotid artery. Whereas the proximal dural ring lies loosely over the internal carotid artery. It separates the third nerve from the internal carotid artery. The segment of the internal carotid artery between the proximal dural ring and the distal dural ring is commonly the C5 or the clinoid segment of the ICA. We also note that there is extension of the anterior intercavernous sinus along the posterior dural ring loosely, and it can cause venous plexus, that is called as clinoidal venous plexus. Subsequently, we'll see the slides which show that. The distal to the distal dural ring is the C6 segment of the ICA. It gives rise to the ophthalmic artery, which lies in close relation with the optic nerve. As seen here, the anterior clinoid process is covering the clinoidal segment. In B, we see that the anterior clinoid process and part of the optic nerve has been sectioned to reveal the branch of the ophthalmic artery from the ophthalmic segment of the internal carotid artery. Make a note of the distal dural ring and the third nerve and the fourth nerve and the V1 and the 6 closely entering into the superior orbital fissure. We also see the branches of the meningohypophyseal trunk arising from the posterior genu of the internal carotid artery and subsequent branches from the ophthalmic segment and the supraclinoid ICA segment. It's a brief, it resembles a collar. So this is called as a carotid collar between the distal dural ring and the proximal dural ring. A point to note, ICA becomes intradural after the distal dural ring. What are the relations of the anterior clinoid with the cavernous sinus? We all know the cavernous sinus resembles a ship. It has a roof, it has a medial wall, lateral wall, anterior and posterior wall. But important is the roof. As we have seen here, the anterior petroclinoid and the posterior petroclinoid form the roof of the cavernous sinus. Anteriorly, we have the clinoidal triangle, in which the clinoidal segment of the ICA resides. Posteriorly, we have the oculomotor triangle, where the third nerve enters into the cavernous sinus. The anterior wall, inferior aspect of the ACP and the optic struct are related to it. Laterally, we all know it is related to the superior orbital fissure, as seen here. A brief note has already been mentioned about the clinoid venous plexus. This is a nice anatomy showing the removal of the anterior clinoid process, ophthalmic artery, the optic nerve, the clinoidal segment of the ICA, the third nerve, fourth, V1, as it enters into the superior orbital fissure along with V1 and sixth nerve. We can see the Caesarean ganglion lying inferior to it. What are the variations of the anterior clinoid process? We need to also know that there are variations in the anterior clinoid process. It does not have the same anatomy. A special mention about keratoclinoid foramen. It is formed between the anterior clinoid process and the middle clinoid process. It is located on the roof of the cavernous sinus. As seen here, this is the keratoclinoid process. This is a middle clinoid and anterior clinoid. It is formed between that. The keratoclinoid foramen can be complete or it can be incomplete, and it is commonly associated with interclinoid osseous bridge. So this has to be carefully looked for. Why is this important? If there is an inadvertent fracture of this osseous bridge, it can cause vascular and neural injury. Hence, identifying this is of paramount importance. So we have to study the pre-op CT well in order to locate for this foramen. The area to look for it is between the anterior clinoid and the middle clinoid, and that's the keratoclinoid foramen. It is due to the ossification of the keratoclinoid ligament. We all know the anterior clinoid process has a thick outer shell and spongy bone inside, but sometimes there can be variations and pneumatization. So how frequently do we see this pneumatization? It is quite common. It is divided as pneumatization can be seen only in the left or it can be seen only in the right. Sometimes it can be bilateral. There are gradings in this pneumatization of the anterior clinoid process. Type 1, if only less than 50% of the anterior clinoid is pneumatized. Type 2, more than 50, and type 3 is completely pneumatized. Failure to identify the pneumatization of the clinoid process can result in CSF leak. It's important to identify and close the area of defect. This is an interesting study on 72 paraclinoid aneurysms that has been done in Japan. They have looked at both sides, so almost 144 sites. And it was predominantly female, unruptured aneurysms and ruptured were included. And in their series, almost 16% corresponded to the keratoclinoid phenomenon, almost 1/4. Intraclinoid osseous bridge was seen in 3%. Pneumatization is also seen in 20%. So this study stresses the importance of studying the pre-op CT in order to evaluate the clinoid anatomy. This is an interesting picture to look at the anatomy of the clinoid process through endoscopy. This is a dorsal clinoid space, and this is the anterior clinoid process. Recently, there's been a study which studied about the removal of tumors located in this space. But I think some more studies are required in order to gain the experience in trying to remove the anterior clinoid, as it has a very close relation to the carotid artery. This is a picture, again, which stresses the importance of the falciform ligament, the distal dural ring, the proximal dural ring, the optic strut, and the anterior clinoid, and the relation to the supraorbital fissure. To conclude, the clinoid process is vital in skull-base surgery because of its intimate relationship with the neurovascular structures. It's a high-risk zone because of the anatomical variations and proximity to the key vessels. Preoperative CT imaging is essential to study the bony anatomy and detect pneumatization, as it aids in surgical planning. Knowing the anatomy well improves the outcome. Thank you for this time and opportunity.
Thank you so much, Dr. Edmond, for finishing your talk on time and emphasizes about the neurosurgical anatomy of anterior clinoid process as well as the clinical implications. So we will have discussion at the end of all the 3 talks.
Thanks, Dr.
Thank you, sir. Now, I would like to take this opportunity to introduce our second speaker, Dr. Ravi Mohan Rao, who is Professor and Director of Neurosurgery at Apollo Hospital, Seshadripuram, Bengaluru. Over to you, sir.
Thank you, Dr. Ved Prakash. Thank you,
Thank you.
Dr. Roopesh. I have to share. Is my slides visible?
Yes, sir.
Yes, sir.
Thank you.
Visible, sir.
Ravi,
Yes, sir.
I'm desperate to listen to you. You are a wonderful speaker, and more than that, you're a wonderful surgeon and a human being. Please carry on.
Thank you very much, sir, for your generous comment.
Thank you.
I'm going to talk on extradural clinoidectomy. My personal preference is to do extradural clinoidectomy in almost all cases, except 1 or 2 exceptions, which I'm going to show in my talk. So these are key techniques, skull-base techniques, which are small segments of skull-base surgery like extradural or intradural anterior clinoidectomy, anterior petrosectomy, posterior petrosectomy, and partial 1/3 occipital condylectomy. So these kind of procedures add immensely to the procedure when indicated. So in the logic of skull-base approaches, why do we need to do that? I'm taking an example of a low-lying basilar apex aneurysm to indicate that the importance of doing anterior clinoidectomy. You see that the optic nerve and the intercarotid artery are tethered by the distal dural ring and the falciform ligament. So moving these structures can be difficult. In this, though there is wide appreciation of the basilar bifurcation, sometimes the carotid artery and the optic nerve can hide the basilar bifurcation. And by doing an anterior clinoidectomy and cutting the distal dural ring and the falciform ligament, we are unlocking, so-called unlocking of the optic nerve and the internal carotid artery is done. So these can be maneuvered to have a look at the interpeduncular fossa. And also in this case, posterior clinoidectomy is also required to visualize the proximal basilar artery. So similarly, the porous oculomotoris can be opened. We saw an excellent anatomy demonstration. So by opening the porous oculomotoris, we also allow the third nerve to be mobilized. So all these 3 structures become mobilized after doing an anterior clinoidectomy for visualizing deeper structures in the interpeduncular fossa, as shown in this picture. We had already an excellent exposure of the anatomy. This is the lesser wing of the sphenoid ending in the anterior clinoid, the optic canal, and the roots, the superior root, the inferior root, and the lateral root. And the importance of drilling the optic now, the anterior clinoid carefully is, as already told by Dr. Jonathan, the superior division or the third nerve is separated very, very closely. It's related very closely to the optic strut, and hence it needs to be removed very carefully to avoid injury to the oculomotor nerve. The optic canal is separated from the supraorbital fissure by the optic strut. And this is a view of the distal dural ring, the proximal dural ring. The proximal dural ring is also called as the carotid oculomotor membrane. So you are seeing that the carotid artery is separated from the oculomotor nerve by the proximal dural ring. And underneath this is the carotid collar, which was already mentioned. So by removing the anterior clinoid in carotid ophthalmic aneurysms, we get proximal control intracranially itself, rather than expose in the neck. So why do an anterior clinoidectomy extradurally? The advantages of doing it extradurally is there is dural protection of the brain, the temporal lobe. When you need to expose the anterior clinoid, you need to retract the frontal and the temporal lobe extradurally, and the temporal lobe is protected from retraction injury. The draining veins, the superficial and deep middle cerebral veins, which go to the sphenoparietal sinus, along with the sinuses and the superficial middle cerebral veins are retracted backwards. So there is no venous injury. The ICA too is protected. The interdural ICA is protected. The optic nerve is protected by the dura. And even in dorsal wall aneurysms, carotid ophthalmic aneurysms, the dura protects the aneurysm to some extent. So in very large carotid ophthalmic aneurysms, I do the extradural drilling under intermittent temporary clipping in the neck, temporary occlusion of the ICA in the neck. Then, to my mind, a bigger advantage is it prevents bone dust dispersion inside the dura. And when you are doing it for some meningiomas, at least meningioma cells dispersion inside the dura is also prevented. I'll show some examples of meningioma to illustrate the point. So this is an example of a small suprasellar meningioma extending into the optic canal. And then here you see, after doing a craniotomy, this is the temporal lobe, the frontal lobe. This is the lesser wing of the sphenoid, the meningoorbital artery, and this is the sphenoid ridge with the anteroclinoid process. So the dura is pulled back. Dura propria of the temporal lobe is pulled back to expose this is the supraorbital fissure. After cutting the meningoorbital artery and incising the outer layer of the superior orbital fissure dura, we can pull back the temporal dura propria to expose. Here the temporal dura propria is pulled back and the cavernous sinus is exposed, and this is the superior orbital fissure. This is the anterior clinoid, and the third nerve will be somewhere here, just underneath the anterior clinoid process. And this is the drilling being done. And this is the deroofed optic canal. The frontal lobe dura has been pulled back. And this is the anterior clinoid and the optic strut, which is seen here. And after removal of the optic roof, you see the optic canal, and the anterior clinoid has been reduced largely. And then after removal of the optic strut, you see the clinoid segment of the ICA. So the technique to be used is start in the center of the anterior clinoid, drill the porous bone, and the cortical bone is eggshell. That means it is thinned out, and then with a dissector, it can be elevated and removed. Once the tip of the anterior clinoid process is freed from all the roots, the lateral root, the anterior root, and the posterior root. It's free. And the point mentioned already regarding the carotid oculomotor foramen should be noted preoperatively itself to avoid carotid injury while pulling out the tip of the anterior clinoid process. So here you see a meningioma. The anterior clinoidectomy has been done. The meningioma is seen elevating the optic nerve. It's underneath the optic nerve. Arachnoid dissection. And you see the reddening of the optic nerve at the site of compression by the falciform ligament. And the whole thing has been removed. The falciform ligament has been cut open. This is the optic nerve in the optic canal. And the tumor has been removed. This is the internal carotid artery seen lateral to the optic nerve. This is the post-op CT scans, and this shows the anterior clinoidectomy done. And this is the post-op visual fields of this patient, which improved. Another example of a meningioma, a larger, much larger suprasellar meningioma. And the post-op showing the removal. Recently, I did 3 cases of intraosseous meningioma of the lesser wing of the sphenoid and the body of the sphenoid. Here you see the meningioma, which is sclerosing, producing hyperostosis of the anterior clinoid process. I have not put up the MRI because this is best seen in the CT scan. And this is the post-op showing anterior clinoidectomy and removal of the intracranial portion of the tumor and the bone. The sphenoidal portion is still there, which was removed subsequently by an endonasal approach, and the whole thing was drilled out. Another example of intraosseous meningioma, you see this hyperostosis, the meningioma extending intraorbitally and causing visual loss in this patient. So this is the post-op. He had a lazy eye preoperatively, and the eye movements are normal. And this is the post-op showing the anterior clinoidectomy done totally extradurally. And these are the post-op visual fields. And another example of a patient who had an intraosseous meningioma, which was removed. I think the slides are slightly intermixed here. My apologies for the same. This is a patient with a very large intradural suprasellar meningioma. In these cases, I don't do an extradural anterior clinoidectomy for the simple reason that putting pressure on the dura and retracting the tumor along with the dura may likely worsen the visual compression and result in profound visual loss post-operatively. So in these cases, you see the optic nerve stretched over the tumor, and this is the meningioma, which is extending underneath the optic nerve, the suprasellar meningioma. So trying to do it extradurally can put a lot of pressure on the optic nerve and cause significant visual loss. In these cases, I decompress the tumor intradurally and then do an intradural clinoidectomy. This is the sole exception where I don't do an extradural clinoidectomy. And this is the post-op showing excision of the tumor with preservation of the hypophyseal axis. And preoperatively, this is the visual field done 1 month post-op, which shows that the visual field is recovering. I come to an example of a low-lying basilar apex aneurysm, where I used both the Skullbase technique, an extradural anterior clinoidectomy and an extradural anterior petrosectomy, to get proximal control of the basilar artery and do the clipping. So this is the preoperative images showing it's below the level of the dorsum sella. So here the temporal dura propria is being pulled back. This is the superior orbital fissure. This is the multi-axial approach to the aneurysm. This is the middle fossa component. The middle meningeal artery being cut. The dura propria being peeled back. Which exposes the cavernous sinus. So when you do that from front to back, you expose the entire cavernous sinus, superior orbital fissure, the second division and the third division of the trigeminal nerve. So you see the second division here, the third division is here. This is the temporal dura propria being pulled back. And you see the entire anterior clinoid scene. This is the optic nerve, extradural optic nerve. And you do an extradural anterior clinoidectomy because you see almost the entire thing, the central coring out being done. And after excelling, the whole thing is removed. So I'll fast forward this video now. This anterior petrosectomy being shown. So after the anterior clinoidectomy and the anterior petrosectomy, you see the entire bifurcation of the basilar artery, the basilar quadrification. And using Batcher's technique, this is the PCOM, which is this is the P1, which is hypoplastic perforators behind the basilar artery, which need to be saved. So the ring clip allows this perforator to be saved. Putting this ring clip reduces the turgor in the aneurysm and allows the perforator to be dissected off from the neck of the aneurysm. So positioning the ring clip above the first clip in order to spare the distal P1, the P1 on the opposite side, which was caught in the tip of the clip. And a straight clip being applied to include the neck, which is in the fenestrated clip. So the entire aneurysm is clipped now. The opposite P1 is free. The opposite P1 perforators are free. And this is the post-op angiogram. So the advantages of doing an extradural clinoidectomy is it convexitizes a deep-seated lesion and straightens the operative approach. Instead of looking obliquely across the field because of the presence of the sphenoid ridge and the anteroclinoid, removing these structures straightens and shortens the operative approach. In meningiomas, it devascularizes, especially in clinoidal meningiomas and suprasellar meningiomas. To a large extent, it devascularizes the tumor. And then we use, after the clinoidectomy, an extra interdural approach. There is brain protection, as already mentioned, by the dura while doing the anterior clinoidectomy. Venous protection by preserving the superficial middle cerebral veins and the junction with the sphenoparietal sinus. We talked about detethering of the ICA and optic nerve, so-called unlocking them. There is a wider angle of approach, and as shown, it helps in proximal control of basilar artery in low-lying basilar bifurcations. So its applications can be in clinoidal meningioma, medial sphenoid meningioma. Here I do an intradural clinoidectomy as shown in the example. Carotid ophthalmic aneurysms, basilar apex aneurysms. You don't really need to do a anterior clinoidectomy in trigeminal schwannomas because the entire tumor is lateral to the clinoid process. Just an extra interdural mobilization of the temporal dura propria is enough to expose the trigeminal schwannoma in the Meckel's cave and get a view into the Meckel's cave. And if it's a dumbbell trigeminal schwannoma, through the porous trigeminus, you can remove the posterior fossa component. So a single approach is enough in dumbbell trigeminal schwannomas when this approach is used. Thank you very much.
Thank you so much, sir, for your elaborate talk on extra-dural clinoidectomy. Now I will request Professor Alan Tripathy to introduce our third speaker.
Thank you, Ved. Thank you, Roopesh, and thank you to the wonderful speakers before Manas will be introduced. Edmond and Ravi, fabulous. Now, introducing Manas is not a small task. I probably would need more than 12 minutes to do that, but for the sake of time today, we will say that Manas is my younger brother. I'm so happy to lose the president's post of NSI to him. And I was the first one to hug him in Bhubaneswar when we came to know about it. And Manas has been massive. I don't get the words to express his. He's contributed to the Indian neurosurgery in a big way. You name any surgery that he has done massive number of cases and very good results. We know that very well from his association as professor from Nizams and now the head and director of the teams in Hyderabad. And he's such a affable, wonderful, warm human being. And Manas, it is a pleasure to introduce you as the president of NSI, reigning president. And he's been the president of Skullbase, Vascular, and God knows how many societies. I have bumped into Manas quite a few occasions. He is in a much higher league. I am just a small neurosurgeon in Calcutta. And it is actually very difficult to introduce him, at least in this gathering. Maybe another chance I will get. And I'll say how many medals he has got, how many awards he has got, how many publications he has. I remember Manas for various things, including his classification in petroclival measurement, including his epilepsy surgery contribution, his GBS contribution. Whenever I try to call him, he is operating on acoustic to work in odd time of the day. So Manas, God bless you, and let Lord Jagannath bless you all the time, you and your family. And of course, he is a proud son of two of our very senior professors. His parents, his father, anesthesia professor, and his mom, very well known gynecologist of Odisha. So Manas, it is a pleasure and an honor to introduce you to this very special meeting today. I'm really enjoying, although I'm disconnected from my meeting in Dresden. I enjoy the presentations. I'm sure I will enjoy Manas's. Please, sorry for the long time.
Can you see my slide or not?
Yes, sir. Yeah, we can see, sir. Yeah.
Yes, very, very well, Manas.
Visible,
Please
sir.
carry on.
Yes, slide. Is the slide changing? No? Means,
Yes,
sir. Does the slide change?
Yeah.
Okay.
Yeah. Change.
Yeah. Thank you, Professor Tripathi, for that love and affection you have shown. Means, I know that you promote me more than what I deserve because you know me from my childhood and your respect for my parents. You have shown on me, and thanks for all the encouragement and appreciation. I'd like to thank Dr. Roopesh and Professor Hemant Bhartiya for starting this webinar on basics of skull-base surgery, and for giving me an opportunity to speak on uh, hybrid clinoidectomy. Ravi Mohan and me we did MCH together, and I know that he is fond of extra-dural clinoidectomy. Uh, I I started doing I liked intradural more than extradural, but over a period of time I realized that there is no point in fighting with Ravi Mohan. It's better to do an hybrid clinoidectomy, which is actually takes the advantage of both extradural and intradural clinoidectomy, and can do away with the disadvantage of both. So at present, I practice hybrid, and what I will be speaking on hybrid. So I'll not contradict Ravi Mohan because it's difficult to contradict him. In extradural, as Dr. Ravi said, that there are a lot of advantage that there is no bone dust collection and dural protection to neural structures is there. But then there are certain disadvantages also because uh, it is uh, it is a suboptimal view of the means ICN optic nerve are not seen. It is seen only at the end of the drilling, and hence for people who are starting skull-base surgery, it becomes a little difficult, and we feel that there is no retraction on the frontal or the temporal lobe, but actually there is indirect retraction when you put a dura, though there is CSF protection, but actually there is indirect retraction, and it's not totally extradural. At the end, we have to address to the lesion by opening the dura. So we are just delaying dural opening, but not that we are avoiding dural opening. So it's a purely extradural lesion like a cavernous sinus lesion, chordoma, trigeminal sternoma, where you don't have to open dura, then probably it is advantageous. But when you have to open, either you open it early or late, probably it doesn't make a significant difference. Whereas in intradural, I agree that this disadvantage of the bone dust. Sometimes the drill can slip away and can cause a problem in damaging the nerve. But the advantage is a young neurosurgeon can do safe drilling because the neural structures and vascular structures are under direct view, and you drill with caution and have less chance of damaging the nerve. All these days, I was thinking that extradural or intradural doesn't have difference, but I was surprised with this publication which came recently 2 years ago, the impact of anticlinectomy using drill and no drill, and they said that when one uses drill for the clinoidectomy, the chance of visual worsening is higher than not using a drill. And all of us are used to using a drill. The thermal temperature, the increase in temperature causes damage to the optic nerve. That is why they can have visual loss, as well as then they have a loss of vision because of the oculomotor nerve damage also because of thermal injury. And it's not 1 to 2%, it's almost to the tune of 20% chances of visual worsening. This is what is described in this paper. I'm sure with technique people can reduce the chance of visual loss, but this is what is described in this. And this is again another paper which they compared the intradural versus extradural anterior clinoidectomy, and they compared the visual loss in paraclinoid aneurysms. And surprisingly, here also in intradural they describe as 10% and extradural as 20%. This is something which one has to, this came in 2024. So these articles one has to always keep in mind before being very dogmatic that extradural is better or intradural is better. That is why I have followed the hybrid technique. This modified intradural anticlinectomy is a combination of intra and extradural or a hybrid clinoidectomy, which been practicing for the past 10 years. In this, though we have not published, but this is a very good paper to understand the hybrid technique. The line is can draw a line from the tip of that one. Once you open the dura like a standard dural craniotomy, you draw a line from the tip of the clinoid along the sphenoid ridge. So this is the line, and then dura is incised along this line, and the frontal lobe dura is separated extradurally, and the temporal lobe dura also is separated, and so that the spinoparietal venous sinus can be pushed along with the dura. And once you have the whole dura, the clinoid, exposed like an extradural space, and you can see the ICA also intradurally, the optic nerve. So you drill the clinoid extradurally, but you know where is your anatomy. So these are this case example where doing a clinoidectomy is important. Like this is small cavernous angioma in the anterior cavernous sinus. This is another case of a meningioma in the anticlinoid, pushing the optic nerve and chiasm, having visual loss. Or this is a case of another clinoid meningioma where we usually operate, and at the end of the day, we leave tumors around the clinoid because we are tired. So many times we have to stage it and then take out small tumors, because leaving tumors around clinoid, around optic nerve, then they're not good for radiosurgery. Also, one has to remove small bits of tumor. So if you're tired, maybe better stage this kind of tumor so that all bits of tumor are removed. Or a case like this, recurrent pituitary tumor, where clinoid has to be removed. All these cases, doing a hybrid clinoidectomy is helpful, because and in paraclinoid aneurysms also, because we invariably have to open the dura either early or late. Uh, clinoid anatomy has already been discussed by Dr. Edmond very clearly, but I'd like for drilling clinoid, one also has to understand the oculomotor triangle. The oculomotor triangle is a triangle between posterior clinoid, anterior clinoid, and the petrous apex. So the oculomotor nerve divides the oculomotor triangle into medial hakuba and lateral triangle. So this is the oculomotor nerve goes through the oculomotor triangle. The medial part is the Hakuba triangle, and this is the clinoid. Once you remove the clinoid, you expose the clinoidal triangle. Once you expose the clinoidal triangle, you will have the distal dural ring, the proximal dural ring, and the clinoidal part of the ICA. So this is what, when the clinoid is removed, you see the clinoidal triangle, the distal dural ring, proximal dural ring, the ICA, and this is the oculomotor triangle. So to do clinoidal drilling, and one has to understand the oculomotor triangle, Hakuba triangle, and the clinoidal triangle to have a better visualization of the anatomy and pathology. Once it goes down, as Dr. Edmond told, one can see the V1, V2, and Dr. Ravi also explained while splitting the dura propria, we can identify the V2, V1, V2, V3, and take out the tumor extradurally. So I'll show the video of this case of a clinoidal meningioma. So the first step is this is the temporal part, this is the frontal part. Anterior craniotomy is already done. The superior orbital fissure is exposed. The next step is decompressing the superior orbital fissure by taking out the lateral wall of the orbit. The orbital fissure is open from the till the V2. And then extradural, the posterior part of the clinoid is drilled out, or the means anterior part. The posterior half is removed intradurally. The anterior half is taken out extradurally. So once the anterior half of clinoid is removed, the dura is opened, and the dura is cut along the sphenoid ridge, starting from the tip of the clinoid. CSF is let out so that the brain falls off. We don't have to retract the frontal or the temporal lobe. The sylvian veins draining to the spinoparietal sinus along with the spinoidal dura can be stripped off. So once the one you incise from the tip of the clinoid till along the sphenoid ridge, then the dura on the frontal lobe is separated. Then decompression of the optic nerve is done under direct vision, because you see here the optic nerve, you can follow in the same angle to decompress the optic nerve. And then the optic strut is taken out and the clinoid is removed from medial to lateral. Bleeding from the anterior clinoidal segment of the cavernous sinus can be easily controlled by using Surgiflow. So here the tip of the clinoid was removed intradurally. The anterior part of the clinoid was already removed extradurally. And then one has to identify the third nerve to open the oculomotor triangle. So incise along the third nerve medially to open the Hakuba triangle. Tumor from the Hakuba's triangle and tumor from the clinoidal triangle and between carotid optic nerve is taken out. Tumor on either side of the third nerve is removed. And then one goes, once adequate tumor decompression is done, then optic nerve can be decompressed. So the manipulation of the optic nerve is least once you have removed the tumor. And this is from the anteromedial triangle. This is the carotid. This is the optic nerve. At no point of time we are manipulating the optic nerve. Instead of using drill, you can use bone QSA. Bone QSA also increases temperature, but it is probably less than the drill. And as the bone defected, as Dr. Edmond was explaining, that the sinus can be opened. So you have to plug the defect with fat and fibrillar, and then place pedicle pericranium to prevent CSF leak at a later stage. Pedicle pericranium is placed on the open pneumatized clinoid process. So this is another case of a cavernous angioma, that was a meningioma. The similar steps are done. The first is decompress the supraorbital fissure, drill the anterior part of the anticlinoid process extradurally, and then open the dura like you open this for the pterium craniotomy, and divide the dura along the sphenoid ridge till the tip of the clinoid. Then I let out CSF from the interoptic and carotid optics space, so you can see the carotid and the optic nerve, and then extradural decompression of the optic nerve, followed by sphenoid ridge, and then the optic strut is drilled out. So it's like the temporal dura can be stripped along with the sphenoparietal sinus, so that you don't have bleeding from the by stretching of the temporal pole. So the technique is similar of taking out the clinoid and then opening the, again, oculomotor triangle here, the third nerve is seen, and this is the cavernous angioma in the anterior cavernous sinus. And the tumor is taken out as a single piece, as it's a cavernous angioma. And bleeding can be hemostasis can be achieved by packing with fat or surgery flow. This is a case of a recurrent pituitary. Again, one can do the similar way of identifying the
while the other extends upwards to form the inner layer of lateral wall of cavernous sinus.
peel the periost, the dura propria, extradural. Extradural, you can expose the tumor, take out, do decompression of the tumor.
Please mute yourself. Somebody's Edmond Jonathan, please mute your mic.
Yeah. So the other indication is of a paraclinic aneurysm, and here again he had a carotid exposure to have a proximal control, and then drilling of the lateral wall of the orbit, as I had explained in the previous videos. Then part of the clinoid again is removed extradurally. The tip is removed intradurally. So this is the extradural part of the clinoid removed. The next step is removing the intradural, the tip of the clinoid. So the dura, the spin opened along the sphenoid ridge, as I had shown in the earlier video. And finally, the intradural part of the clinoid is drilled out. Normally, the tip of the clinoid is adherent to the dura along the third nerve. Hence, sharp dissection has to be done before removing the clinoid. Otherwise, while pulling the clinoid, it can have inadvertent damage of the third nerve. That is one of the reasons of having visual third nerve palsy following clinoidectomy. Always remove the clinoid from medial to lateral rather than lateral to medial. If you do lateral to medial, the chances of damaging optic nerve is higher. And again, the bleeding from the anterior cavernous sinus can be stopped by surgery flow or putting a small piece of fat wrapped with fibrilla. So once the clinoid is removed, one is to open the oculomotor triangle. This is the third nerve seen. One is to incise me along the medial border of the third nerve into the cavernous sinus, so that the both proximal and distal dural ring is clearly seen. I'm just cutting because only the upper part of the neck was seen. The lower part is inside the cavernous sinus. I'm opening it to identify the lower part of the neck. The fundus was embedded in the dura, so I had to cut detach the fundus from the diaphragm of the cavernous sinus dura, so that clipping can be applied. Otherwise, while putting the clip, it can be inadvertent rupture. So the next video is is cutting the superior wall of the cavernous sinus around the fundus. It is better to leave a bit of dural cuff on the fundus so that don't damage inadvertently. And once all around incision is done, the fundus is free, then one can apply a clip, because this part, the distal part of neck is exposed, proximal part is exposed, only the fundus is adherent. One is to detach it, and then once that is detached, it is easier to put a right angle fenestrated clip. So now the aneurysm is ready for clipping. The uptake nerve is mobilized medially. It's important to drill the medial part of the optic canal so that the optic nerve doesn't compressed along the medial wall. So the medial wall of optic nerve has to be decompressed well, 270 degrees, so that so as you've already dissected the fundus, the inadvertent rupture of the fundus doesn't happen. And after clipping, check for the patency of the parent artery, and then one can use either yellow fluorescence or ICG to look for the patency of the vessel. So check we did with the yellow fluorescence. So there is no, I'm not very dogmatic about intradural or extradural clinoidectomy. I always do an hybrid. The hybrid, being friendly with Ravi Mohan is always helpful rather than contradicting, and then use advantages of both and don't and avoid disadvantages of both. With this view, I'd like to thank all of you for your attention.
Very, very nice, Manu. I'll let Ved say something, and then Roopesh maybe, and then Dr. Hemant.
Thank
I'm
you
a
so
little
much,
bit
sir.
noisy
Thank you so
surroundings.
much for the elegance demonstration
Taking
of.
taking a tour of the university. So I'll be listening.
Please go ahead, sir. Please, sir. Okay. Thank you so much, sir, for the elegant demonstration of hybrid clinoidectomy and showing the spectrum of cases being managed by this approach. We are really thankful for your nice demonstration of the lecture. So the floor is now open for the questions. So I will request our panelists to please ask a couple of questions.
Ved, can you show the first your case discussions, and then we can ask the panelists and speakers what they would like to do.
Yeah, sure, sir, sure.
I can go back to that. In this one question also in the question box, can cavernous sinus tumor be removed extradurally?
Sir, I think sir should stop sharing.
Who is the question addressed to, Roopesh?
Sir, it's open, sir. You can ask.
The cavernous sinus tumors are interdural. They are not intradural. So an interdural approach, frontotemporal interdural approach, can expose the entire cavernous sinus. And in the lateral wall, you see the third, fourth, and first division of ophthalmic nerve. And the tumor can be approached through one of the triangles and removed.
When do you consider, when do you do intradural work for a cavernous sinus tumor? What are your indications for opening the dura for cavernous sinus.
Dr. Roopesh, please read the names of the people who have asked the question.
This is Dr. Harshad has asked this question. Only one question as of now.
Okay.
Harshad, yes.
No, a cavernous sinus tumor means, to be more specific, is it a meningioma extending into the cavernous sinus?
Yes. Hemangioma as well as large hemangioma of the cavernous sinus. You would like to do purely extradural, or you will also do open the dura and then they combine both extra and intradural.
Even if you go intradural, the tumor is most of the time in the interdural plane itself. It's not pure intradural tumor, a cavernous hemangioma. But whereas meningiomas, which are, say, petroclival meningioma extending into the cavernous sinus, or clinoidal meningioma extending into the cavernous sinus, you need to open the dura. Earlier, we used to chase these cavernous sinus extensions. Nowadays, because of gamma knife and other forms of focused radiotherapy, you don't chase these tumors into the cavernous sinus.
Can I ask one question?
Yes, sir.
So, Dr. Manas, what was the indication of operating on cavernoma in the cavernous sinus?
That was angioma.
Hemangioma.
Cavernous angioma. That was near the optic nerve. I know that they respond well to gamma knife, but it was adjacent to the optic nerve, and that is why we suggested surgery.
But was it causing the visual problem?
Yes, sir. The presentation was visual blurring of vision. That is why MRI was done. It was not incidentally detected.
Okay.
Yes.
Okay, can I comment if you allow me?
Please, sir.
Okay, first, I should congratulate Roopesh for selecting three excellent speakers. And let me just tell what I understood. Jonathan, I never knew that you are such a big skull-base man. Everything you touch on anterior clinoid, you even showed the picture, but you missed about carotid cave. You showed that picture of carotid cave where the outer dural ring slopes from lateral to medial, anterior to posterior.
Yes, sir.
So there is a small redundant space there, which is intradural subarachnoid,
Yes, sir.
which is below the level of the upper level of clinoid, where aneurysms can come, which people call cave aneurysm.
Yes, sir.
Rest everything you touched, Edmond, and I congratulate you for that.
Thank you, sir.
Ravi Mohan. Ravi Mohan is my teacher. We work together. Hats off, Ravi. He stressed the importance of unlocking the optic canal for going to the interpedunculair fossa. Because you unlock the optic canal, remove the optic canal, and then mobilize the optic nerve. Then only you can mobilize the carotid artery medially. And then you are into the interpedunculair fossa. Really, you are my teacher, but one thing you showed a basilar aneurysm. I was at Bhopal where Manas also didn't come, where our Matthew Abraham, he stressed a little more on basilar. He told that one can sacrifice PCOM close to PCA because all the perforators from PCOM to hypothalamus, everything is from proximal PCOM, and you get more space. And he said you can open out everything. Also, he told about. He said all the steps are not necessary, but you can do anterior choroidal mobilization, do fungus removal, everything to open that area. Ravi, you are my teacher. I appreciate. I always enjoy.
You are
And
very generous, sir.
and of course, Manas is such a great surgeon. So nice to know both of you were together. So he can be better than you also. I don't know. But Manas stressed the importance of anterior clinoidectomy producing, extradural producing visual loss. Ravi told that. But Ravi told it is for tumors, it can produce counter pressure on the optic nerve and produce visual deterioration. Ravi, you stressed that, but you didn't stress it for vascular pathology, but where Manas told, he told even up to 20% of the patients can have visual deterioration with the extradural clinoidectomy, and he showed his hybrid technique. Congratulations, Manas. Always nice to listen to you. Okay, that was my comment. Thank you very much.
Yeah. There is also a question now. What is the incidence of transient or permanent third nerve palsy or other cranial nerve palsy traversing through the cavernous sinus? In your experience, does it vary for intra versus extradural approach? Dr. Manas can answer this question.
Yeah. No, means I thought do sorry. Intradural, hybrid or intradural. I started with intradural and I changed out to extradural. But the literature says that in extradural, the third nerve palsy has been reported almost 8 to 10%. And so it is usually because the tip of the clinoid is adherent to the pathway of the third nerve, and so hence one has to, after doing axial drilling, one has to do sharp dissection of the bone, so that you don't cause traction on the third nerve extradurally, because you don't see the third nerve. With intradural, because you see it, you are more careful. The paper which was published in 24 and 23, both of them have stressed that the visual disturbances is quite high in the extradural approach.
Thank you.
Because of third nerve and optic nerve. I'll forward you.
I have a slight difference of opinion here. You see the extradural optic nerve. When you do the
Yeah.
extradural mobilization, you see the optic the dura covering the optic nerve entering the optic canal. So you have a good idea of the location of the optic nerve. And we also use intraoperative neuromonitoring in all cases. So when you're going close to the third nerve, you get a warning about being very close to the third nerve or third nerve manipulation. So with these things and constant irrigation, when you're doing drilling, if you do bone QC also, thermal generation is there. When you use a drill,
Yeah.
thermal generation is there. My technique is to use a small cutting burr where the heat generation is less as compared to a diamond burr, and using constant irrigation. And again, I don't do the full drilling of the clinoid. I excel it and then elevate it out of with roton dissectors.
Yeah.
Okay.
Yes.
No,
There's another.
I'm just quoting what is published in the literature.
I know, Manas. I know that.
Yes.
There is another third question. As per Roton's description, the anterior clinoid has only two true osseous attachments, the optic canal roof and the strut. Is it necessary to drill the lateral extension towards the lesser sphenoid wing as a separate third attachment in practical surgical workflow? Or is it better to do only Roton's two-point anchoring model?
No, the lateral attachment also
Yeah.
hinders its removal. It's a continuation of the lesser wing of the sphenoid. And in extradural, anyway, that is removed first. In intradural, you have to remove both the roots, the anterior root and the posterior root. And the lateral attachment has to be reduced for removing the anticlinoid.
Yeah. Anyway, yes, sir.
Yeah, no, third, rather one has to be careful of four attachments. As Dr. Edmond presented, the incidence of keratoclinoid is almost to the tune of 16%. Can Edmond can clarify that? As far as I heard, he told it is 16%.
Yes, sir.
So it's
The
not
incidence
only
of
two attachment.
is
One has to be
16.
careful.
So we need to
Yeah,
carefully look
so
at the
one
pre-op
has
CT, sir.
to take care of four legs. And if you have a clinoid ligament in CT, then that is one of the contraindication for doing an extradural clinoidectomy also. It's better to
Exactly,
do
sir.
an intradural. That is what is recommended. Yeah.
Correct, sir.
Yeah. So So the question now here is, whenever we are planning all these peniodal meningioma, most of the time patients come with an MRI brain. Is it necessary to do a CT scan in these patients, or is it we can go ahead with only the MRI? In what time when we do additional CT for medial sphenoidal meningiomas?
I think I'll agree with you that it's always better to do a CT scan if you're planning clinoidectomy instead of just depending on the MR.
Yeah.
Yes, Manas, we do CT as a complementary addition. It's not exclusive. CT and MRI are not exclusive. So many a time we do a CT as complementary information to be derived from the bone windows.
Any tips on opening the meningo-orbital band? A question from Dr. Ashwin.
Sometimes it can be the supply to the eyeball, and it can reportedly can cause visual loss due to occlusion of the meningo-orbital artery. But otherwise, I have not faced it personally. It's said to be in 10% of cases to be the sole supply to the eyeball. I'm not too sure because I have not come across that. And as soon as the supraorbital fissure is exposed by retracting the temporal dura propria at the end of the exposure, medial end of the exposure, you see the meningo-orbital artery entering the orbit. So there it is sectioned sharply, coagulated and sectioned sharply.
Ravi, there is something which has come where they have written how to avoid lacrimal nerve injury during cutting of a meningo-orbital band. I forgot to prevention of lacrimal nerve injury, which comes at the lateral part of the superior orbital fissure. So when you cut this meningo-orbital band, it is at risk. I forgot how to prevent that. You can read literature.
But sir, in order to expose the cavernous sinus, pull back the dura propria, you have to cut the meningo-orbital.
No, you have to cut. I agree. But while cutting, there is a technique to prevent lacrimal nerve injury. That's what I am telling. Okay.
Understood, sir. But again, you have to cut the outer layer of dura propria only and pull back the temporal dura propria.
For carotid ophthalmic aneurysm, do you have to have carotid control in the neck before drilling ACP? I think Dr. Manas showed one video. So, do you always expose the neck?
I actually means after doing the fellowship, no, when I came back and practiced, I was overconfident. I used to do without exposing the neck, and but as I gained experience, I feel more comfortable exposing the neck, having a proximal control. So it all depends on you. But now I prefer to be on the safer side, expose the neck because but if you are very confident, you can do it without. But I had once problem of when there's a rupture of the neck of the aneurysm, you have no control. Even if you have put a clip, temporary clip on the ICA in the clinoidal segment, it is not adequate. So I do with always expose the neck.
Okay, sir. There is a question from Dr. Abhinav. He's asking that during basal cystonostomy, we put a drain as described by Dr. Ayapsharian. Can the drain tip cause damage to the neurovascular structure? So I don't think about which drain he is talking about.
No, usually the cystonostomy drain is just a ventricular catheter or external ventricular drain. So usually if you take care and place it properly, you may not damage the third nerve. And we have seen many instances where the drain can be pulled out even safely without any injury.
Yeah.
It can be put safely.
So I have a question to Ravi Mohan, sir. Can I ask the question? Am I allowed?
Please, please.
Yes, sir. So that separation of the temporal dura propria, you used to do blunt separation, or you used to sharply cut the temporal dura propria while separating from the lateral wall?
all
There
the
are
time.
two layers.
Yes,
According
sir.
to Professor Kawase, there are two layers, the endosteal dura and the dura propria, which go into the orbit. So if you cut the superficial layer at the supraorbital fissure and then holding the dura propria with forceps, you can pull back the dura propria. So the initial cut is sharp, followed by just traction and pulling back the dura propria.
Okay, once we reach the correct plane, then it will peel off easily.
Yeah, it will peel off easily. It's a relatively avascular space, except for the communications with the cavernous sinus, which can bleed. But that bleeding is easily controlled with either Surgicel, Surgiflow, or any other fibrin glue.
Yes. Thank you, sir. Thank you. So, Roopesh sir, can I share that case?
Yes, yes. We can ask the
Kind
panelists,
permission.
yeah, their opinions.
Is my slide visible, sir?
Not yet.
Very nice cases you showed, Manas. Superb cases.
Yeah. Yes, sir. 1 second. Is it visible, sir, now?
Yeah, yeah. Yes.
Dr.
This was
Ved
the case.
Prakash, is a supraclinoid aneurysm, isn't it? PCOM supraclinoid aneurysm.
Yes, sir. ICP-COM. Yes, sir. Supraclinoid.
Yeah, by definition, it won't need an anterior clinoidectomy, I feel, for a PCOM aneurysm, because you have a segment of ICA distal to the clinoid, which
Yes, sir.
for temporary clipping. What do you feel, Manas?
Maybe sometimes there can be a very short supraclinoid
Yeah. So the
segment.
lateral. Can you show me the lateral view? No, just the lateral without rotation. Just want to see the lateral view.
Dead lateral.
Yeah. Or if you have a DSA lateral view also is okay.
No, sir. We couldn't have DSA. So we operated her on CT angio only.
In
And
this
I thought this video could be
CT
good
angio
enough.
lateral view because it looks like part of the neck means clinoid probably is the lower part of the neck is covered by the clinoid, so that means if after opening you don't find the lower, then you have to do an intradural clinoid drilling, I think.
Yes.
Okay, sir.
What did you do?
So we did, sir, extra-dural clinoidectomy because on CT angiogram we were afraid of this part of the ICA. This was significantly narrowed as compared to the rest of the part of the ICA. So we expected that there could be thrombus, which might be dangerous if we put the temporary clip. And after measuring the distance of the aneurysm neck to the tip of the clinoid, it was less than 2 millimeters, sir. So we were afraid that we could not get
Space.
the proximal control.
Proximal control.
Yes, sir. So to get the better proximal control and do without putting a temporary clip over the ICA, we can, if we could safely clip the aneurysm. So that was the whole rationale for doing the extradural clinoidectomy. And at our center, we are little bit pro towards the extradural clinoidectomy instead of doing hybrid and intradural. Couple of cases we have done intradural also, in which we got stuck. Then we have done
But what
intradural.
was your finding intradurally? Was
After
what?
Yeah, sir, it was significantly shortened, sir. Significantly shortened, and it was atherosclerosed. The vessels were atherosclerotic significantly.
So in
So
any case, putting a temporary clip on the ICA would have been difficult because of atherosclerosis.
yes, sir. Yes, sir. So we did direct clipping and patient did well. And already patient presented with third nerve palsy, sir. So the patient is on the 6th post-op day.
But Ved Prakash,
Yes, sir.
this narrowing was it because of the thrombosis or because of the clinoid bony compression?
No, sir, there was not, like, compression was not there. We expected that there could be atherosclerosis because on CT angiogram that much we can expect.
You could see the calcium in the vessel wall.
Yes, sir. There was atherosclerosis plaque, sir.
Now, when you have a doubt, is it not better to do a DSA?
Yeah, yes, sir, definitely we should have done, but we could not get in this case. We had proceeded without getting the DSA.
Ved Prakash, before this rotational CT angio all came, say based on angiogram itself, as you correctly told, sometimes PCOM will have, it behaves like a ophthalmic segment aneurysm. They have very short supraclinoid segment. So there were some articles which showed the angle between ICA and the cavernous ICA. And depending upon that angle, one could predict based on angiogram whether the supraclinoid ICA is short or not, and then do a clinoidectomy. I forgot the literature. You can check that. It is written
Sure,
both for not only for PCOM but also for choroidal also. Okay,
okay,
very
sir.
good.
Nowadays, some studies are available, sir, which predict whether we should go ahead with a clinoidectomy in case of ICA PCOM. As you are very well mentioning that there are certain literature available. So
Now
we
you have
also,
rotational angio and all, you can find out. Long old days, it never used to be there. Based on angiogram and angles, we have to derive whether it is a short supraclinoid segment or not.
yes, thank you, sir. We'll definitely have a review, sir. And this was a case of clinoidal meningioma. I think Manas sir has already shown a very beautiful illustration and demonstration of clinoidal meningioma. So nothing much new in this case. So we did extra-dural clinoidectomy in this.
Dr. Ved Prakash, don't you find it difficult because of the bulk of the tumor, mobilizing the dura becomes a little tough?
Yes, sir, definitely. Definitely, sir. It was challenging, but we proceeded with this because patient was already having significant visual diminution in this case. Only PL positive was there, sir.
But most of the time, these clinoidal meningiomas, intradurally, if we do, only tumor will be seen, or unless we decompress the tumor significantly, it will be very difficult to see an intradural portion of the dura of the clinoid. So most of the time, I feel this is easier to do extradural in these cases than doing intradural, because we will be seeing it at the end.
That's true, Roopesh, but the bulk of the tumor, along with the vascular supply going from the bone into the dura and tumor, makes it difficult to mobilize and expose the clinoid extradurally for a complete extradural clinoidectomy. And also, it will be pressing when you mobilize the dura, you will be pressing on the optic nerve more because of the bulk of the.
Whenever such cases, but extradurally, if we can drill out the optic canal also, I think probably we may avoid that. So the pressure of the optic nerve may be better.
Yeah.
We can do along with the clinoidectomy, we drill the optic canal.
Yeah.
But,
yeah, that's a Roopesh and Ravi, hybrid. If you do hybrid, no, all this confusion will not happen.
yeah, but Dr. Manas, it is interesting to see the person who does
Yes.
most of the extradural here is saying against it, and you being doing a hybrid. So
Now both Ravi and Roopesh were were contradicting each other, which is better. No, means what I'm telling is we are discussing like six blind men discussing describing an elephant. If hybrid is like you take advantage of both.
Both. Yes.
No, I agree.
Yes.
This is one particular case, supracella meningiomas, clinoidal meningiomas, where I tried to do extradural, but end up doing intradural at the end of removal of the tumor. Because there a clinoidectomy becomes essential with deroofing of the optic canal, because most of the clinoidal meningiomas will have an intraoptic canal extension of the tumor.
Agree, sir. Agree. Sir, Ravi sir, in your presentation, you told you temporarily put clip in the neck.
Pardon?
You put during drilling, you temporarily used to put clip in the neck.
For large carotid ophthalmic aneurysms.
Yes, sir.
Yeah, while mobilizing the dura of the clinoid, I put a temporary clip for 2 to 3 minutes. I temporarily occlude the cervical ICA to reduce the turgor of the aneurysm, so I don't have an intraoperative rupture. And if the dura, if it is intact and it has not, dura is very tough. And generally the aneurysms don't cross the dural barrier.
Yes.
So it is possible to mobilize, even if it is stuck to the dura, the fundus or part of the aneurysm is stuck to the dura because it's a carotid ophthalmic aneurysm. Along with the dura, the aneurysm also gets mobilized and intraoperative rupture is less. And I use intermittent clipping to reduce the turgor while doing this maneuver.
Okay. While putting the clip, you can be little bit more aggressive to mobilize the dura. That is the rationale. Yes. So, in your experience, sir, have you ever encountered visual complaints while doing extradural clinoidectomy?
Extra-dural clinoidectomy, in one or two cases, I think the vision has reduced, but then subsequently it always improves during follow-up. If the optic nerve has been thoroughly decompressed and vision is well preserved preoperatively.
Okay.
If the vision is severely compromised, then chances of recovery are less.
Will be dismal. Yes, definitely.
Dr. Raghavendran, any comments? Panelist.
Yeah, generally what I would prefer is an extradural clinoidectomy for all my cases, except for aneurysms where sometimes to define the neck, you may have to go around the aneurysm and continue with your drilling until you can define the neck and clip the aneurysm. And I would request Ravi sir's opinion regarding this. Generally, I prefer to do extradural always. But in cases of aneurysms, large aneurysms in the clinoid segment, paraclinoid segment, sometimes you can see the dome of the aneurysm, but the neck to be defined clearly, you have to drill around the aneurysm so that the neck is defined well.
Before Ravi tells, I will tell. Say, ophthalmic segment aneurysms, most of the aneurysms project medially. Luckily, God has been kind to us. Very few only project laterally. So even for ophthalmic segment aneurysms, you can do extradural clinoidectomy. And in the group of ophthalmic segment aneurysms, it is the carotid ophthalmic aneurysm, which arises the dorsal wall. Dorsal wall aneurysm only, you require this clinoid removal, then unroofing the optic canal, then everything, cutting the distal dural ring, everything you have to do so that you have to see the proximal carotid and proximal neck. Otherwise, you won't see the proximal neck unless you drill the clinoid and do rest of the procedure. You don't see the proximal neck and also the proximal carotid. So it is mandatory you should do a clinoidectomy as opposed to ventral wall aneurysm. Many a time you may not require. God has been so kind, most of these aneurysms project medially, but sometimes they project laterally, where this is, you have to do intradural or whatever our people have told. Now we review your comments.
Then I just have to add a little bit. The ventral wall aneurysms are superior hypophyseal aneurysms.
Yeah.
The clipping technique is with a right-angled fenestrated clip where the fenestration holds the ICA.
I see.
So you don't need to do a clinoidectomy because of the clipping technique. You use a fenestrated clip which is right angle to cover the neck of the aneurysm.
And clip is put from distal to proximal. Distal to proximal, as opposed to a dorsal wall where you put from
proximal to distal.
And that is a right angle clip.
Or a curved clip.
Yeah, correct. Right angle clip. Yeah. Distal. Okay. You are correct. I agree with you.
So for dorsal wall aneurysms, which are also called as carotid ophthalmic aneurysms, unless you cut the distal dural rings, as you correctly told, you don't see the proximal ICA, which is the clinoidal ICA or the very
proximal neck also you won't see.
Neck also you don't see. So for those reasons, you have to do a clinoidectomy.
Absolutely correct.
Large aneurysms, carotid ophthalmic aneurysms, I have a fear of the drill touching the aneurysm and causing intraoperative rupture. That's why I do an extradural clinoidectomy. Using
Manas, what he does? Manas.
Sir, exactly. I agree with you, sir. We do an extradural clinoidectomy in most of the cases, but sometimes after a complete extradural clinoidectomy has been done, intradurally, there is a difficulty in locating the proximal part of the neck.
Correct.
Unless you drill drill around the aneurysm, sometimes the dome are partially towards the neck. It is very difficult to locate the other side of the neck. That is the proximal.
I understood what you said about drilling the clinoid. After drilling the clinoid, what else is there to drill? I'm not getting.
If you see, I had a case where it was looking like a pituitary macroadenoma. It was coming through the cella. So the neck was actually exactly in the clinoidal segment and the medial aspect. So
it was a transitional aneurysm. Transitional aneurysm. Part extradural, part intradural.
Yes, sir. So even after clinoidectomy, we had to drill around the planum sphenoidal until the extent where we can locate the proximal side of the neck, so that the clip can be applied. In such situations, is it advisable to do an entire intradural clinoidectomy?
It's difficult in intradural, according to me, but Manas can do it, I suppose.
No, I told I practice hybrid, both extra intradural combination, so that I don't have any confusion in my mind.
Yeah, correct.
Because doing.
I think we have overshot our time, but it's a good discussions. So Dr. Hemant sir, your final comments, you can then close our session.
I want to request Roopesh put this on YouTube.
Sir, yes, sir, definitely. If all the speakers agree, we'll send a signed consent form, and if you're agreeing, then we will put it up in the session.
And also mention, Dr. Roopesh, that this is for Professor Suresh Nair. That if God had been kind, why he would have given that patient an aneurysm? So he was not very kind.
Hemant, you are a good friend of mine. Thank you for the comments and excellent talk. Edmond, I never understood you are such a great speaker, Edmond. Always, great talk. And of course, I expected this level of talk from Ravi and Manas. And of course, also. Great.
Thank you, sir.
Thanks, Roopesh. A great show.
Thank you, sir.
I don't attend, but today I thought I should listen to this talk.
Thank you, sir. Thank you, sir.
Thank you so much, sir.
Thank you, sir. Thank you.
I congratulate everybody. Good night. Bye-bye.
Thank you, sir.
Bye, sir.
Good night. Good night.
Bye.
Thank you, sir.
Bye.
Bye.
Thank you, everyone.
Good
Good
night.
night.
Good night. Good night. Everyone.
Thank you,
Good
sir.
night.
Thank you, Dr. Bhartiya and Dr. Roopesh, for organizing the event.
Bhartiya,
Thank you,
thank
sir.
you. Bye, bye,
Thank you,
Bhartiya.
Dr.
Roopesh,
Bhartiya,
Bye.
Roopesh.
Bye, Raghavendran.